I have the pleasure to start this off talking about some of the new tests and the new algorithms, and we'll be focusing on an increasing number of new tests tonight and different applications for those tests. But in particular, from the perspective of diagnostics, it's really sort of time for us to move on from what we've been doing for a long time. Looking at the timeline of HIV tests, the first EIA was introduced in 1985. And subsequent ones were introduced after that. The Western blot and the IFA were actually approved by the FDA in 1991 and 1992. Subsequent to that, third generation EIA as early as 1992. The original EIA was withdrawn, and as we continue to go through the progression of tests as they were introduced, including rapid HIV tests, what we see is that now we have a majority of tests that are either third generation or fourth generation assays that detect IgM antibodies and IgG antibodies and P24 antigen. But our screening tests are all third and fourth generation. The rapid HIV tests that are being used in many point of care settings are second generation that only detect IgG. And our confirmatory tests are the same ones that we were using 20 years ago, which are the first generation IgG detecting Western blot and IFA. So we're in a situation where most of our screening tests are much more sensitive during early infection than the tests that are usually used to confirm those infections. And I think the evidence has become pretty clear that if we rely on the old 1989 recommendation, which is to follow a repeatedly reactive screening test with a Western blot or an IFA before giving out a positive result, we are going to give out the wrong results to some people who have early infection detected by the newer and the better tests. So looking at what this means from a clinical perspective, this is a cartoon that looks at the appearance of laboratory markers in the course of HIV infection, starting at point 0, the time of infection. There's an eclipse phase when basically nothing is detectable from HIV. Then RNA appears. Subsequent to that, P24 antigen appears, and as antibody develops, P24 is difficult to detect, and then first IgM antibodies and IgG antibodies develop and persist throughout the course of infection, and antibody tests have been our mainstay. Acute HIV infection is defined, at least from the perspective of public health, as the interval between the time that RNA appears and a person becomes infectious and the time that infection becomes detectable. So putting those generations of tests basically into perspective, the first generation test detecting infection at around 50 to 55 days has a very long period of acute HIV infection where a person is infectious but might be misclassified. Second generation tests improve that window somewhat down to about 45 days from the time of infection. Third generation tests, with their ability to detect IgM antibodies, made a substantial improvement. And now, with the fourth generation assays able to detect P24 antigen, the interval of acute HIV infection is down to about 5 or 6 days between the appearance of RNA and the ability to detect infection with a laboratory marker. This is an uninterpretable slide from CDC's laboratory. What we basically did is looked at 26 seroconverters with a variety of specimens and evaluated all currently FDA-approved assays on the seroconverter panels. In order to make some sense out of this and interpret it, we looked at basically when each test was able to detect HIV in 50% of the specimens in the seroconverter panels. Obviously, with seroconverters, there are different intervals between bleeds. They're not exactly comparable. And so this is really 50% cumulative frequency. It's not exactly a matter of window periods. And of course, we don't know when people became infected. We do know when their Western blot turned positive. And so what we did is looked at this 50% cumulative frequency and compare it to when the Western blot would in fact detect infection, and that was considered at point 0. The Viranostica assay, which was in use by 2/3 of public health laboratories and both commercial laboratories until as recently as 2006, picked up infection about 2 days after the Western blot turned positive. So the Western blot was a fine confirmatory assay that was withdrawn from the market in 2007. The point of care lateral flow rapid tests are depicted here. Each of them identify HIV infection by identifying IgG antibodies between 1 and 5 days before the Western blot. The laboratory-based tests are a little more sensitive. They're immunoconcentration assays, the Reveal G3, the Multispot, and another EIA that's still available on the market, the Aviac, pick up infection about a week before Western blot turns positive. The INSTI is a most recently approved rapid HIV test. Again, a slightly better interval of detection. The DPP, and I'll talk more about the dual path platform in just a few minutes, again about 8 days before Western blot turns positive. But what most laboratories are using are either third generation assays, which detect infection about 2 weeks before the Western blot, or fourth generation assays, which pick up infection about 3 weeks before the Western blot turns positive. And then, of course, the earliest detection by the Aptima RNA assay is about 26 days before the Western blot turns positive. There is also currently, before the FDA for approval, a rapid point-of-care test. That's a fourth-generation test, and it is slightly more sensitive than the laboratory-based third-generation assays in early infection, but not quite as good as the laboratory-based assays that detect both antigen and antibody. So what we see in terms of what the window period is that it depends very much on what test you use. And the real difficulty, of course, is that relying on a repeatedly reactive assay and something like the Western blot to confirm it will not identify a lot of people very early in the course of infection. Why does that matter? Well, looking at populations that have high incidence, this is sensitivity now among frequently tested men who have sex with men in Seattle. And in this particular study, they ran each of these assays as well as pooled RNA and identified that 192 men were infected with HIV. Of those, 23 or 12% were detected only by RNA assays. Now, of those, 16 were available to be tested with antigen antibody assays, and 15 of those 16 were picked up by the fourth generation immunoassays. But 88% of them were detected by the serum antibody immunoassay, and 80% of them were detected by the oral fluid rapid test. And many of them had been screened initially with the oral fluid rapid test, and then it became identified that a tremendous number of infected people were being missed. So essentially, when we look at a point-of-care rapid test, it has 80% sensitivity if you use RNA as the standard for what is present. Most laboratorians then go on to say, well, why don't we end up using RNA as a confirmatory assay? And numerous studies have shown that between 2% and 4% of specimens that are submitted for testing from people who are antibody positive, including a fully developed Western blot, test negative for RNA. So there is no perfect assay at the current time, and everything requires an algorithm. CDC and the Association of Public Health Laboratories proposed a new diagnostic testing algorithm in 2010 at the HIV Diagnostics Conference, and subsequently has conducted a large number of validation studies. And that new algorithm, which was described in the June MMWR, starts with a fourth generation HIV 1-2 immunoassay. If that test is reactive, or if the manufacturer requires repeatedly reactive, it is followed then by an antibody assay, and in particular an HIV-1, HIV-2 antibody differentiation immunoassay. Part of the reasons for doing this differentiation assay is that starting in 1992, the CDC recommended that if laboratories were using an HIV-1-2 assay, one that detected both HIV-1 and HIV-2 antibodies specifically, if the Western blot was negative or indeterminate, you should go on and test specifically for HIV-2. The results of that testing indicated that somewhere between 50 and 85% of individuals with HIV-2 infection would yield a HIV-1 Western blot result that was positive for HIV-1 because of cross-reactivity. And so the idea here in terms of beginning or following the initial assay with this antibody differentiation assay is both to identify people who have antibody and to identify people who have HIV-2 infection rather than having some other criterion for figuring out who to test for HIV-2. In this new algorithm, if the differentiation assay is positive for either HIV-1 antibodies or HIV-2 antibodies, that is reported out as evidence of HIV-1 or HIV-2 infection, and the individual should be referred to care. There is some cross-reactivity, and so on occasion there will be a positivity for both HIV-1 and HIV-2, which needs to be resolved with additional testing. That's just considered HIV antibodies detected, and further testing is required. But if that second test, the antibody assay, is either negative or indeterminate, and I'll talk about that interpretation in a minute, it should be followed by a nucleic acid test. And this is the step that will end up picking up people with acute HIV infection that are detected by the combo assay and are antibody negative. Some evidence of how this works. This was also published June 21st of this year. An emergency department in Phoenix, not usually considered an epicenter of HIV infection in the U.S., had conducted fourth-generation screening of patients in their emergency department, all patients who were having blood drawn. When testing was offered, only 15% of the patients declined testing. Of the 13,000 patients who were tested, 37 of them had new, previously undiagnosed HIV infection. But the remarkable thing is that 12 of those, or a third, 33%, had acute HIV infection. In other words, they were antibody negative and would not have been detected by rapid tests. They would not have been detected by third-generation assays. And when we looked at these people more closely, the median viral load among the patients with acute infection was 6 million. And the median viral load among patients with established infection was 25,000. And so what we're looking at is basically in our screening, and in particular screening patients in emergency departments, the most infectious people would have been given a negative test result in our current schema of HIV testing, which is the reason for the new algorithm, the reason for proposing it. Obviously, the proportion here in the emergency department with acute HIV infection is a function of the fact that acute HIV infection is associated with symptoms, and people were going to the emergency department for symptoms of acute HIV infection. Had they not been tested, they would have been sent out with a diagnosis of a viral illness, despite the fact that they were very infectious with HIV. And the issue with acute infection is there is a very high risk of sexual transmission. As I've already demonstrated, the level of virus, the viral load is extremely high during this initial 3 or 4 week period of infection. Clinically, acute HIV infection is considered usually to go out to around 6 to 8 weeks. Even after antigen and antibody begin to appear, there are still high levels of viral load. But in addition to these very high levels of virus, it's a different virus. Animal studies, at least, looking at the virus that actually establishes infection, and it's usually only one specific virus that gets across, that virus that establishes new infection is somewhere between 75 and 750 times more infectious per virion, so that in the animal studies, when they looked at the dose of virus that it took to establish infection, virus present during established infection was much less infectious than the virus that was present during acute infection. So we basically have a perfect storm effect of very high levels of virus, usually very high levels of sexual activity, and a much more infectious virus than that one that's present during the long period of established infection. The test that's used, the antibody differentiation assay that's FDA approved for use in the algorithm, is the multi-spot HIV-1, HIV-2 rapid test. It is a CLIA moderate complexity test to be performed on serum or plasma. Takes only about 15 minutes, and it was FDA approved for use as part of a diagnostic algorithm, in fact, as a part of this diagnostic algorithm, in March 28th of this year, so that we now have basically the fourth generation assays approved by the FDA, we have the differentiation assay approved by the FDA, and we have an approved NAT by the FDA, so that we have all the tests that we need to conduct this new algorithm. And as was pointed out in the MMWR on June 21st, laboratories can adopt this algorithm and begin testing in this direction because all of these tests are currently available. And the validation studies indicate that this performs much better than the current algorithm, and the cost is either similar or somewhat less than the current algorithm. And as you can imagine, the turnaround time by using a moderate complexity single-use rapid test as your second assay in the algorithm is much faster than when it required a Western blot. Most hospital facilities sent Western blot out in order to be detected. And under CLIA, most laboratories were not supposed to report the initial reactive immunoassay test results, and so people who were positive didn't find out. For me, this was very perplexing because a person with minimal training could perform a rapid HIV test and give a result, but a laboratory could not perform a high complexity or moderate complexity immunoassay and provide that result until it was confirmed by a test that wasn't as good as the first test that was used. So the differentiation assay, the multi-spot, has two indicators, a recombinant protein and a synthetic peptide for HIV-1, and it has a synthetic peptide for HIV-2. In order to be interpreted as positive, both HIV-1 antigenic determinants, both the recombinant and the peptide, need to be present. So one of the reasons in this algorithm that you report out the results is that after a repeatedly reactive fourth generation assay and positive multi-spot, you actually have 3 different pieces of information, 3 different positive results. And the new interpretation as a test used in the confirmatory algorithm, if only one HIV-1 spot is present on the multi-spot, that result is considered indeterminate, and indeterminate tests should go on to nucleic acid testing. The implications of the new algorithm is that we now have the ability to routinely detect acute HIV infection. Obviously, from the public health perspective, it's an important focus for partner services and intervention efforts. Studies have shown that people with acute HIV infection name 2.5 times as many sex partners, and of those sex partners, twice as many are infected with HIV as partners elicited from people established with HIV infection. CDC is putting out a new surveillance case definition so that people who have this laboratory definition of acute infection will be considered stage 0 HIV infection. Stage 0 will cover anyone who's been infected within the last 6 months, so that people who have previous evidence of a negative test and a subsequent positive test within a 6-month period will also be stage 0. I think importantly, we will have the ability to detect and identify HIV-2 infections. HIV-2 infections obviously cause false negative results with viral load tests. They don't respond to many antiretroviral antiretroviral agents, including the non-nucleoside reverse transcriptase inhibitors and several protease inhibitors, so that HIV-2 does not respond to first-line therapy that we give for HIV. And unfortunately, in the past, most HIV-2 infections were discovered when people with a negative viral load were deteriorating clinically without an explanation, because they had a positive HIV-1 Western blot, a negative viral load, yet they were manifesting clinical progression. That resulted in investigating them and resulted in identifying that they in fact had HIV-2. So the new algorithm recommendation is to start screening with a 4th generation HIV-1, HIV-2 antigen antibody combination immunoassay. I just learned from the FDA that these antigen antibody combination assays are called combo tests, and the HIV-1, HIV-2 antibody tests are called COM-B tests. Only the FDA could think of that. In the second test that should be used, if it's the first immunoassay is reactive, is the antigen antibody immunoassay that differentiates HIV-1 from HIV-2 antibodies. Persons who are positive, the specimens that are positive on this second assay, should be considered positive for HIV and reported out as laboratory evidence of HIV infection detected, and then undergo the initial workup, which calls for a laboratory test that include viral load, CD4, and antiretroviral resistance assays. We do have alternatives in the recommendation that will be coming from CDC, such that if people use a 3rd generation assay as their initial test, then you should still perform subsequent testing as specified in the algorithm, but laboratories should report out these results with a limitation statement, indicating that this algorithm may miss some people with acute or with early HIV infection. If an alternative second test is used, in other words, you can still use the Western blot or IFA, it's still on the market. If that is negative or indeterminate, you have to perform an HIV-1 NAT. If the NAT is negative, you have to perform an assay for HIV-2. This will have the potential to miss certain infections, but you have to do a lot more testing if you end up using the Western blot or IFA as your second assay. If you use NAT as your second test instead of the antibody test, if it's positive, of course, you have evidence of HIV-1 infection. If it's negative, you still have to perform an HIV-1, HIV-2 antibody differentiation assay. As I mentioned, about between 2% and 4% of specimens submitted to the laboratory that are antibody positive for HIV are negative for NAT, so that if you do NAT as your second test, you can't stop. The indication statement in the package insert for the currently approved assay for RNA indicates that quite specifically. It's a conditional assay, so that if it is positive after a repeatedly reactive immunoassay, it confirms HIV infection. If it's negative, it does not rule out HIV infection. The disadvantage of this, at least from CDC's perspective, is that for the people who are positive on the NAT, it won't differentiate whether they're acute infection or not. It will only tell you that they have HIV. And as we'll hear from Chris Pilcher a little bit later, it's actually important to figure out the difference between whether a person has acute HIV infection or not. So these recommendations will supersede the recommendation for use of the Western blot that were issued in 1989, the recommendations for HIV-2 antibody testing, which were issued in 1992, and also the protocols for confirmation of reactive rapid tests. Currently, the recommendation for a reactive rapid test is that you should go on to do a confirmatory test regardless of the results of the initial assay. That recommendation was issued when the Viranostica was a predominant assay that was used, and some of the rapid tests were more sensitive in early infection than the Viranostica was. This will screen for both virologic and serologic markers of HIV infection. It incorporates nucleic acid testing to resolve discordant test results. It will identify acute HIV infection as acute infection and drastically reduce indeterminate results. And of course, all the immunoassay positive specimens will be tested for HIV-2. On the horizon are a couple of things that we'll be talking about tonight. One of them is the thing I mentioned, the combo rapid HIV-1, HIV-2 antigen antibody test. We won't be discussing that, but that test, at least as it's currently designed, has one indicator for antibody, one indicator for antigen, as well as the internal control. We're beginning to refer to these as fifth generation assays, the one that differentiates antigen from antibody, because the current fourth generation assays just tell you they're reactive. They don't tell you whether it's antigen or antibody that's present. We'll also be talking about the next generation of HIV-1, HIV-2 differentiation assays. This is the Genius supplemental assay, and Pierre will present some of the data that was generated for its European approval. This uses the dual path platform. And the dual path platform, again, is a new technology. It's sort of the successor to lateral flow, so that you apply the specimen from one direction, allow it to flow and saturate the strip, and you apply the conjugate from another direction. And basically what this does is several things. If you look inside the cartridge, what you see essentially is that there is a strip where the specimen is applied, and it cleans the specimen. So you can use whole blood or serum or plasma specimens. And it also allows for multiplexing, because the antigens can go up and they can saturate a variety of lines before the conjugate is applied, which goes across in the other direction. So it allows for a lot more accuracy. It's a different technique built on the lateral flow concept. The Genius also has software which allows for automated reading and validated results from this assay, and you can archive the test results so that, unlike what many laboratories have concern about now, which is that rapid tests don't interface with LIS, they don't basically get things into the record or generate bills. This will end up solving that kind of difficulty. And I'll mention a few things more in a minute about that. But the other thing we won't be discussing tonight are the next generation of simplified amplification assays. There's a variety of assays that are now nearing readiness for the market that can generate a nucleic acid test result in between 30 and 45 minutes and are suitable for using individual specimens. This is one particular example of that that has a sort of a prep module and an amplification module, and it generates a qualitative result. In the qualitative mode, it either tells you that virus is present to a limit of detection, or in a semi-quantitative mode, it tells you basically there's a threshold with a different technique that the viral load has risen above 1,000 copies per milliliter. But we will be talking about assays to determine recent HIV infection. And this idea of being able to identify acute and recent infection is important. Going back to this diagram I started with in the beginning, the interval basically from the time that RNA appears through 6 months after infection has clinical significance, and Chris Pilcher is going to be telling us about that. Until now, we basically haven't made much distinction. People were positive or negative. There's some qualitative reasons where there's a real difference in terms of looking at the period of recent infection and its response to therapy. So what we'll be talking about today, Pierre will give us some performance results of the Genius in its European clinical trials. Chris Pilcher will talk about the importance of detecting recent HIV infection. And then Mike Bush is going to talk about another entire application of tests for recent infection, which is basically looking at this in order to measure HIV incidence, to sort of say how we're doing with the epidemic. And we'll follow that up with a session on questions and answers.